If you are over 65 and there are several prescriptions sitting in your kitchen right now, this matters. Not because every pill is dangerous, not because your physician is careless. It matters because an older heart carries less reserve, less flexibility, and less room for error than it did 20 years ago. A medication that looks completely harmless on paper can become a serious load in a 70-year-old body. And over the next several minutes, I want to show you exactly how that happens. By the end, I will give you 7 medications or medication groups that deserve a serious cardiac risk review, not so you panic, not so you stop anything tonight, but so you walk into your next appointment informed, calm, and ready to ask the questions that most patients never think to ask. Because the goal is straightforward. Protect the heart you still have. And stop blaming age for what might actually be the treatment sitting right beside your vitamins. Most people expect heart trouble to arrive with drama, chest pain, a crushing, unmistakable event, something no one could possibly miss. But that is not how it usually begins in older adults. Sometimes it starts with shoes that feel inexplicably tighter. Sometimes it is less stamina on the stairs, a new flutter in the chest on a quiet afternoon, a strange fatigue after a light breakfast. And sometimes the trigger is not the disease at all. It is the prescription. That is the part families rarely see coming. You feel responsible. You take the medicine exactly as prescribed. You assume that compliance means safety. And in many cases it does. But there is one detail that changes everything in an older body. The older the heart, the more a normal side effect stops being normal. A little fluid retention is not little when the heart is already working at its limit. A small drop in magnesium is not small when the heart depends on steady electrical signaling to maintain rhythm. A mild reduction in contractile force is not mild when the pump is already borderline. That is the nuance I want you to hold throughout this entire video. And I will close with the specific checklist I wish every family brought to clinic visits. But first, let me show you 3 patients. Their names are changed. Their stories are not. Michael was 73. Arthritis in both knees, persistent lower back pain, and the kind of daily discomfort that turns a simple walk to the letterbox into a negotiation. He wanted real relief. His physician gave him a prescription, anti-inflammatory. Nothing unusual. Millions of older adults take similar drugs every year. At first, Michael felt genuinely better. He moved with more ease. He slept more comfortably. He could stand at the kitchen stove longer without wincing. And that early improvement created a dangerous illusion, because while his joints felt quieter, his circulation was becoming louder. These drugs can instruct the body to hold on to salt and fluid. They can raise blood pressure, and in some people, they make the heart work harder with every passing hour. Michael did not notice it at first. He only noticed that his shoes felt tight by afternoon. Then his breathing shifted. Then he needed 2 pillows at night to sleep without feeling breathless. Then one morning, he was sitting completely still and still felt short of breath. That was when his son drove him to hospital. His lungs were backing up with fluid. His heart was failing to keep pace. And the anti-inflammatory medication was a significant part of that picture. Did the medicine cause everything by itself? No, that would be too simple. Michael already had an aging cardiovascular system, mild kidney strain, and elevated blood pressure that had been creeping upward for years. But the drug tipped the balance. That is how this usually happens. Not one villain, a stack of small burdens, a body with limited reserve, and one medication too many. The practical lesson from Michael's story is this. If you are over 65 and you use anti-inflammatory pain pills regularly, do not judge them by pain relief alone. Judge them by swelling, by breathlessness, by blood pressure, by sudden changes in fatigue. Those 4 signals matter. And if you keep ibuprofen or naproxen at home just in case, remember that phrase, just in case. Because just in case pills have a way of becoming every morning for the knee, every evening for the shoulder, twice on difficult days, before anyone notices the pattern. And that pattern is exactly what overloads an older heart over time. Elena was 69, high blood pressure, a faithful approach to her tablets, and the kind of patient who never wanted to make a fuss. She did what she was told. She took the medication. She kept going. She trusted the routine. For a while, everything looked stable on paper. Then she started feeling drained in the middle of the day. Not sick, just strangely empty. She described her legs as heavy in the supermarket. Then came the first dizzy spell. She dismissed it. Then the second. Then on an ordinary afternoon in a brightly lit shopping aisle with a basket half full, she fainted. When the evaluation was completed, the picture was serious. Her heart muscle was weaker than expected. There were signs of cardiomyopathy, and a significant part of the clinical concern centered around the calcium channel blocker she had been taking for blood pressure. Now, let me be precise. Not every calcium channel blocker creates the same level of concern. Some are genuinely useful and entirely appropriate for many patients, but certain ones, particularly in older adults with existing heart muscle weakness, can reduce the force of cardiac contraction. And when contraction is already marginal, that reduction matters enormously. A younger heart compensates. An older heart may not have that capacity. That is the difference clinicians sometimes underestimate. A prescription can produce a perfectly controlled blood pressure number on the chart, while quietly reducing the pumping strength the heart needs to keep blood moving through the body adequately. Elena did not feel cardiomyopathy. She felt tired. She felt slow. She felt off. That is another trap. The warning signs are often completely ordinary. And ordinary symptoms get blamed on age, on the weather, on stress, on poor sleep, on not eating enough. How many people watching this have been told, your tests look fine, you are just getting older? Be honest. If that happened to you, you are not alone. And sometimes that sentence delays the deeper review that should have happened considerably sooner. The practical lesson from Eleanor's story is not to fear blood pressure treatment. The lesson is to ask one specific extra question. Is this particular drug the best match for my age, my current heart function, and my complete medication list? That question, asked directly, can change everything. Robert was 77. Different problem, different medicine, same pattern, years of reflux, burning after meals, a sour taste at night, the need to sleep slightly elevated, eventually placed on a proton pump inhibitor, a stomach acid suppressor. Common, frequently appropriate, often helpful, but Robert stayed on it for years, not weeks, not months, years. And over time, one of the hidden costs emerged. Lower stomach acid can interfere with the absorption of magnesium. Slowly, quietly, no dramatic headline symptom, just a mineral balance drifting in the wrong direction. Month after month, refill after refill. Magnesium matters for muscles, for nerves, and critically for heart rhythm. When levels fall far enough, the heart's electrical system becomes less stable. That instability can show up as palpitations, skipped beats, a racing pulse, or persistent atrial fibrillation that refuses to settle. Robert eventually developed exactly that. A stubborn, irregular rhythm that would not respond cleanly to treatment. When the team reviewed the full picture, chronic acid suppression was identified as one of the key contributing factors. And this is where many people become frustrated. They ask, why was nobody checking for this? The honest answer is uncomfortable. Sometimes nobody checked because the medication was working for the original symptom. The reflux improved, so the prescription stayed, and the longer a medication stays, the more invisible it becomes. It stops feeling like an active treatment. It becomes furniture. That is dangerous. Any drug that has been in your daily routine for years deserves a fresh clinical look, especially after 65, not because it is automatically wrong, because your body today is not your body from 8 years ago. Your kidneys may be different. Your magnesium handling may be different. Your heart's electrical reserve may be different. Now step back and notice the pattern in all three stories. Pain relief became fluid stress. Blood pressure control became pump weakness. Reflux control became mineral depletion, and rhythm instability. Different doors, same house. The aging heart pays for side effects more aggressively than any other organ in the body. And here is the part the public rarely hears clearly enough. Many medications are studied first in populations that do not resemble the people who ultimately use them most heavily. Healthier adults, fewer concurrent diseases, fewer prescriptions, more organ reserve, better recovery capacity. A robust 52-year-old in a controlled trial is not the same as a 76-year-old taking 7 medications simultaneously. That gap matters profoundly. Medicine does not fail only through bad drugs. It also fails through bad fit. A reasonable drug in the wrong body, at the wrong age, under inadequate monitoring conditions becomes a serious problem. And the monitoring piece is where the system most often slips. Not because every physician is negligent, because modern care is rushed, fragmented, and overloaded. One specialist manages blood pressure, another manages pain, another manages reflux, another manages mood, another renews prescriptions at refill visits, and everyone assumes someone else has reviewed the complete interaction picture. Sometimes nobody really has. That is not evil. That is speed. And speed is dangerous in older hearts. Let me now walk you through all 7 medication risks. I review first when an older patient with cardiac concerns sits in front of me. Not to help you self-diagnose, not to help you stop anything independently, but to help you know exactly what deserves a careful, documented conversation. First, non-steroidal anti-inflammatory drugs. Ibuprofen, naproxen, diclofenac. These are everywhere. Prescription cabinets, bathroom drawers, travel bags, bedside tables, supermarket shelves. People use them for knees, for backs, for shoulders, for headaches, for the inflammation that comes with simply being in an older body. Here is the science in plain language. These drugs can instruct the kidneys to retain salt. That pulls in additional fluid. More fluid means more volume for the heart to push through the circulation. And if blood pressure rises simultaneously, the workload climbs again. For an older adult with borderline heart function, that double burden is serious. The practical move is direct. If you take these regularly, ask your physician How regularly is too regularly for your specific cardiac situation? Ask whether swelling, weight gain, or breathlessness should prompt an urgent review. Ask whether there is a safer pain management approach for your particular case. Do not assume over-the-counter means harmless. That assumption is responsible for a significant number of hospital admissions every year. Second, certain calcium channel blockers, specifically diltiazem and verapamil. Not every calcium channel blocker carries the same profile. I want to be precise about that. But these two can reduce the force of cardiac contraction while also affecting electrical conduction through the heart. And when an older heart is already working below its full capacity, reduced contractile force can become reduced output throughout the body. Reduced output becomes fatigue, becomes dizziness, becomes exercise intolerance, sometimes becomes fainting. Here is what to do. If you're on one of these drugs and you feel worse rather than better, ask whether your heart function has been formally reassessed recently. Ask whether your symptoms could reflect reduced pumping efficiency. And if you have ever been told at any point that you have cardiomyopathy, bring that up immediately. Do not leave it vague. One better number on a blood pressure chart can hide one worsening body. Third, proton pump inhibitors, omeprazole, pantoprazole, esomeprazole. These are often continued for far longer than originally intended, especially when the original reflux was severe enough to make stopping feel frightening. The cardiac risk here is less obvious, which is precisely why it gets missed. Stomach acid plays a genuine role in absorbing nutrients, including magnesium. When acid suppression continues for months and years, magnesium can fall quietly, and low magnesium destabilizes heart rhythm, worsens muscle weakness, and deepens fatigue. The practical step. If you have taken one of these for an extended period, ask whether it is still clinically necessary. Ask whether magnesium levels have been checked recently. And ask whether a step-down plan is appropriate if your physician agrees it is safe. Fourth, thiazolidinediones, pioglitazone and rosiglitazone. These belong to a family of diabetes medications that can improve certain metabolic markers. But in older adults with cardiac vulnerability, there is a known and documented concern: fluid retention. That phrase sounds manageable. It is not manageable when it means the circulation carries extra load around the clock, and an already tired heart must push harder against that increased volume. Shortness of breath appears sooner. Ankle swelling appears sooner. Existing heart failure patterns can worsen measurably. The practical instruction: if you take one of these medications and your ankles are swelling, your weight is rising quickly, or your breathing has changed, mention the drug by name in your consultation. Do not simply say, "I feel puffy lately." Say the name. Ask specifically whether this medication could be contributing. Details accelerate good medicine. Fifth, tricyclic antidepressants, amitriptyline, doxepin, and related drugs in that family. These are sometimes prescribed for mood, for nerve pain, for sleep, for chronic pain syndromes, and sometimes they are genuinely helpful for those purposes, but they can affect cardiac conduction, the electrical timing of the heartbeat. Specifically, they can prolong what is called the QT interval. You do not need to memorize that term. You only need to understand what it means. The heart's electrical reset cycle becomes less stable, and less stable electrical timing increases rhythm risk, particularly when these drugs are combined with other medications that affect the same pathway. Older adults are not one-drug patients. They are interaction patients. A medication that is manageable in isolation can become genuinely risky inside a crowded medication regimen. The practical move. If you take a tricyclic antidepressant, ask whether your rhythm risk has been formally reviewed in the context of everything else you are taking. Ask whether an electrocardiogram is warranted, and ask whether a safer alternative exists for the condition being treated. Do not accept "you have been on it for years" as a complete clinical answer. That is not a review. That is inertia. Sixth, dronedarone. This one surprises people because it is prescribed specifically for heart rhythm problems. So the natural assumption is that it must be protecting the heart. Not always. In certain patients, particularly those with any history of heart failure, dronedarone can worsen the overall cardiac situation. And this is one of the most important principles in all of clinical medicine. A drug can target exactly the right symptom and still be the wrong drug for the complete patient. That is not a contradiction. That is clinical reality. If you or someone you care for takes dronedarone, ask these questions directly. Was this prescribed in the setting of any heart failure history? If yes, what monitoring is currently in place? What specific symptoms should prompt urgent review? And what was the clinical reasoning for choosing these over available alternatives? Those are fair questions, necessary questions, and a good clinician will welcome them. Seventh, and I am returning to this deliberately, the everyday anti-inflammatory habit. Yes, non-steroidal anti-inflammatory drugs, again, because this is where older adults are most consistently trapped. They do not see themselves as medication users. They see themselves as people who only take something now and then for a knee that flares up, a shoulder that stiffens in cold weather, a back that protests after the garden, but now and then becomes every morning, every evening, twice on difficult days, extra before travel, more through winter, then a refill, then a larger bottle, then years pass, and all the while blood pressure creeps upward, kidney strain accumulates, fluid builds, and the heart quietly loses ground. Frequency hides behind familiarity, and familiarity lowers fear. That combination, sustained over years, is genuinely dangerous. Before you do anything with what you have just heard, one thing must be stated clearly. Do not stop any medication independently. That can create new and serious problems extremely fast. Stopping blood pressure medication suddenly, stopping rhythm medication suddenly, stopping mood medication suddenly, stopping diabetes medication suddenly. Each of those carries a real risk. The goal here is not rebellion against your treatment plan. The goal is review. A thoughtful, documented, complete medication review that includes the heart, the kidneys, the electrolytes, your age, and your full prescription and supplement list. All of it together, not bottle by bottle, not symptom by symptom. Everything simultaneously, because the older heart does not experience medications individually. It experiences the combined load. One drug holds fluid, another slows electrical conduction, another depletes magnesium, another reduces contractility, another stresses the kidneys over time, and suddenly a body that looked stable on a refill visit ends up in the emergency department 6 weeks later. The system reviews drugs in fragments. Your body leaves them as a single compounding bundle. That is the missing nuance. That is the most dangerous gap in older adult cardiac care. Here is the checklist I want you to bring to your next appointment. Write these down. Ask whether you use non-steroidal anti-inflammatory drugs, ibuprofen, naproxen, or diclofenac, more frequently than you realize. Ask whether a calcium channel blocker, diltiazem or verapamil specifically, is still the best match for your current heart function. Ask whether long-term proton pump inhibitor use, omeprazole, pantoprazole, or esomeprazole, is still clinically necessary, and whether magnesium levels should be checked. Ask whether a thiazolidinedione diabetes drug, pioglitazone or rosiglitazone, could be contributing to fluid retention or worsening cardiac load. Ask whether a tricyclic antidepressant is affecting your rhythm safety, and whether it has been reviewed against everything else you are taking. Ask whether dronedarone, if prescribed, is appropriate given your complete cardiac history, including any heart failure history. And then ask the question too few patients ever ask: which of these medications, taken together, creates the greatest cardiac risk for me personally? That final phrase matters for me personally, because good medicine is individual, not generic, not carried forward from last year without review. Individual. Let me give you one more practical step before your next visit. Place every medication on the table, every prescription, every pain pill, every reflux tablet, every sleep aid, every supplement. Take a photograph or write a complete list. Then write 3 things beside each one. Why am I taking this? How long have I been taking it? What changed in my body after I started it? That simple exercise exposes more risk than most people expect. Because sometimes nobody remembers who originally started a particular drug, whether it still has a valid clinical purpose, or whether the original reason for prescribing it even still exists. That is how older adults accumulate years of therapeutic baggage, and the heart pays the running cost. One final point, particularly for men over 50 watching this: do not confuse toughness with safety. Putting up with dizziness is not strength. Ignoring ankle swelling day after day is not discipline. Explaining palpitations away as nothing is not wisdom. It is delay. And delay is exactly how manageable medication problems become hospital problems. If this video helped you see a medicine cabinet differently, share it. A like tells the platform that this conversation matters to older families and deserves to reach the people who need it most. And subscribe, because the next video I want to bring you covers which specific symptom combinations suggest a medication problem rather than aging. That conversation could save months of confusion and unnecessary investigation. The goal is not to take fewer pills at any cost. The goal is to make sure every pill still makes sense for the heart you have today. Not the heart you had 10 years ago. Not the heart from a clinical trial population. Your heart, your age, your reality. And if you remember nothing else from today, remember this: in older adults, common medications become uncommon risks when nobody reviews the whole picture. Fix that one problem, and you reduce a tremendous amount of avoidable harm. Quietly, intelligently, one informed question at a time.